Jackson for putting this together with Tien so that we could at least meet virtually, if not by live in Tampa. And I was so looking forward to Tampa. And thank you to, it looks like 250 participants right now for being here this morning at 7 o'clock in the morning. I would love to think it was for me, but I know that you care about education and that's important. And as I've seen some of the chat hellos already, I love seeing this wide range of participants, from new pharmacists, even some students, some technicians, some wonderful names that I recognize like John Noriega and Betty Harris are online. So thank you everybody for making the effort to be here this morning. Now, yes, my name is Jose Ray. I would love to say that I'm well dressed, wearing a suit and tie, like you would normally see me on stage, but here we are at my house, and I buttoned up my shirt for you, so I hope that looks professional enough for our virtual presentation. Now, we're going to spend about the next hour and a half talking about ADHD and autism, and for a lot of us, it will probably be a review, and in that we see these medications on a regular basis. Has there been anything changed? The diagnostic criteria changed from when we were training in school? Those kind of things I'll touch on. And we'll ideally have a little bit of time set aside to address some of the questions that we'll get through the chat. So keep that in mind. If you have a question that comes up during the presentation, go ahead and jot it down and plan on entering it into the chat as briefly and as simply as possible. General questions are, of course, a little bit easier than case-specific questions. I don't want to get into any kind of consults right now. And I do want to set aside some time to address those questions as we go through. If I see them pop up on the chat as I'm speaking, I might address them in stride right there in the middle of it to break it up a little bit. So the chat seems to be working. Okay. We've had a couple of questions from actually, this is going to be something that I'm sure Tien and Mr. Jackson will address a little bit later, as far as linking up and filling out the forms to receive credits and such. That's just not my area of expertise. That sounds like important stuff there. Let's go ahead and get started. I'm going to share my screen right now and show you my slides. And again, I'm really happy that FPA, and I really want to thank FPA for recognizing the importance of mental illness, recognizing that these are things that are just as important as a viral pandemic. And I have to say, being pharmacist on the front lines, seeing our patients, whether it's in the community or the hospital setting, there's a lot of mental health stress going on right now in our country. And that's going to be a secondary impact, not just stress on the healthcare workers, but stress on our families and ourselves. I really didn't have an appreciation for the term cabin fever until my family, myself, 6 of us, all in a small house 24/7 for an entire month. And I love my family, make no mistake, but I don't know how much I love them. That's being tested right now. So we'll see how that plays out as far as our social distancing and our efforts to try to minimize the spread of this particular virus. Now, this particular problem that we're in right now, this health crisis that we're in right now, is not helping any type of mental illness. I hope it's not impacted our patients' ability to get access, whether it's to their practitioners for prescribing. My daughter just had a virtual appointment with her physician yesterday. And so it looks like telemedicine and virtual medicine is advancing as we speak day to day. Our pharmacies are still cranking it out, working like there's no tomorrow. And this extra stress that we're under can impact even a condition like ADD and ADHD and autism, because a lot of our children, and even ourselves, but a lot of our children need routine. They need these kind of behavioral cues and these routines in their lives. And these routines have been upset, and therefore Instead of dealing with the problem in both the academic setting at school and now dealing with the problem at home, like ADHD, now we're dealing with the problem at home, and our children are having to convert to virtual education. And sometimes we as parents and some of our teachers were not equipped for that transition in academics. And therefore, I've noticed an attention deficit when it comes to some of the activities of school, even here in my own household, because of the virtual responsibilities to make your appointments, to work on your homework, and to work on these activities, these academic requirements as we go through. So I don't think we've done any favors for ADHD or autism when it comes to this particular crisis as well. And so it may be affecting almost all of our mental illnesses in a negative way, of course. Let's go ahead and get started and do an overview of ADHD and autism for the next hour and 15 minutes and progress from there and see how it goes. So, when it comes to children, we still should care about evidence-based medicine, and I'm going to touch on that a couple of times. Also, the different classes of medications available for these conditions, and where do they fit in treatment? Where do they fit in our, well, are they the sole treatments, or should we be using other interventions? And yes, the short answer is yes. And then maybe some of the differences between our medications, between the psychostimulants and the other medications that will be used to treat ADHD and autism. As I said before, the medications are very important, but cognitive and behavioral problems might respond to other medications, not just the stimulants. And can they respond to the non-pharmacological interventions? And again, short answer, yes. But ADHD and autism might have a lot of other comorbid situations that we're dealing with. And because of that, we might be using other medications that might be off-label and not specifically approved for the condition, but are effective for the symptoms. And we'll kind of wrap up in the direction toward autism when it comes to what's approved and what's being used. Evidence-based medicine in children, absolutely important. When it comes to ADHD, no disease state and no set of drugs has probably been studied more than the psychostimulants. We have evidence, we know it works. Any one particular child probably has about an 80 to 90% chance of responding to a stimulant if that is the desired first-line treatment. And psychostimulants are the recommended first-line treatments for the average diagnosis for the average child with ADHD. All right, but there are other options out there in case tolerability has been a problem. And again, will these medications be used in autism? Yes, it is a possibility as well. When it comes to the kids, sometimes it's hard to get large sample size, but we do get adequate sample sizes to get most of these medications approved. Now, sometimes we've made these leaps that if it works in a kid, it'll work in an adult. Sometimes we make the inappropriate reverse leap of faith or leap of logic, where it worked in an adult, does it work in a kid? Aren't they just small, tiny adults? Well, the short answer to that is obviously no. And therefore, it is still important that we do the research in the children if we're going to use these medications in the children. I'm going to touch on that a little bit later because I've noticed a kind of a trend in the indications for our psychostimulants that is a little disconcerting. I've just said that if it works in a child, it has a good chance of working in an adult, but these assumptions are being made or inferred by some of the newer medications approved for ADHD, even without the research backing it up. And I'll touch on that as we go along. Now, and again, when it comes to ADHD, these medications have been used and studied for over 50 years. We have efficacy data, and it's replicable. It actually comes and comes and comes. There's really no doubt that the psychostimulants are effective for ADHD, and therefore it's still very important to recognize that they are the gold standard. Now, I agree that I would love to see larger studies. I would love to see more data, more studies of all psychotropics in the children. Sometimes our children are still being given medications that are not approved for that age. The research just wasn't generated, maybe because it was too difficult to get that many kids with that particular diagnosis together. Maybe that's the case. Maybe it's still an ethical concern to give your 3-year-old, your 4-year-old, your 5-year-old, your 6-year-old medications, especially since these are still placebo-controlled trials if they're done properly, which means half the kids may not receive the actual treatment. So we still are seeing some limitations in the research when it comes to the use of medications in our children. Now, when I'm talking about psychopharmacology in the kids, we are again talking about ADHD and autism. Sometimes we break up into different groups, 3 to 5 years old, preschoolers, the pre-K kids, or the really young ones that are not in school yet. And the symptoms of ADHD and autism can easily present in these ages, right? But sometimes to get a diagnosis, you have to have the problem in more than one setting, not just the home setting, but in the academic school setting as well. Maybe the structure of the home environment is sufficient enough to where the symptoms are managed behaviorally and not necessarily with medications. Most of the children, the average child with ADHD, is being diagnosed around age 7, okay? The more severe, maybe the earlier they were diagnosed, maybe 5 or 6, but the average kid with an average diagnosis, with an average set of symptoms, if we can put it like that, is being diagnosed around the age of 7. Now, what is the prevalence of ADHD right now in our children before we get into the diagnostics and what are the symptoms? Well, according to the American Psychiatric Association, it's 5%. Now, according to the CDC, and we've been paying a lot of attention to the CDC these last couple of months, no doubt, it's nearly double that. It's 10 to 11%. Now, CDC goes with the incidence or the prevalence of children being diagnosed with ADHD. So think about that. APA says that the prevalence is about 5%, and that's extrapolations as well, and from some surveys and such. CDC says that 11% of kids are being diagnosed. So you have that medical information coming in and that this is a lot of kids. That's better than 1 in 10 being diagnosed with ADHD. I don't know if the prevalence is that high, but that's what's happening. The reality of it is that we may be overdiagnosing ADHD, but that means some kids who might not have it are getting diagnosed with it. But there's a subset of individuals who have the symptoms of ADD or ADHD that aren't being diagnosed, and they're still having trouble academically, behaviorally, in multiple settings. So though I might be on the soapbox that says we are overdiagnosing ADHD, I recognize, and I want us to all recognize, that there is a group of kids who are going untreated. And that's going to lead them down a bad path, whether it's academics or behavior or secondary problems that might even include truancy and poor academics that go on to where they're not successful. And then that's going to have a secondary effect on depression and anxiety and other behaviors and interactions with others. So yes, we might be overdiagnosing them in one group, but we might be underdiagnosing it somewhere else. So it seems to be a moving target because some of the data seems to indicate that the incidence or the prevalence, I know those numbers are slightly different as far as how we calculate them and such, but it looks like it's going up. In the last few years, there has been a 30–40% increase in the diagnosis of ADHD. And I don't really know how that could happen. Maybe we're better at finding it, or maybe we find it when it's not even there. To have a 40% increase in the diagnoses of ADHD in the last few years is a little disconcerting for me. Why is it such a high prevalence now, but it wasn't there 20 years ago? It probably was there 20 years ago, going undiagnosed. Our thresholds seem to be changing. So right now, 5 to 11% of our children seem to have the diagnosis of ADHD. It is still males more than females. It's still males more than females. However, uh, that number for girls seems to be going up as well because girls weren't as hyperactive. Girls were more inattentive, and therefore they weren't behaviorally as obvious in their symptoms. And so maybe we're underdiagnosing ADHD or ADD in girls, and maybe we're overdiagnosing a little bit in boys because the boys are running around being boys. And I don't like to do that stereotype all the time because boys will be boys, girls will be girls, that sort of thing. But it looks like boys and girls will present differently. And that sometimes makes for a diagnostic problem as well. Now, here's a little interesting tidbit that I picked up recently. And this might be diagnostically oriented as well, or who gets seen and where do they get seen. It seems like if you are an English speaking child, you have 4 times the risk of having ADHD than a non-English speaking child. I can't believe that ethnicities and races and things like that are that different. They really aren't. But the Hispanic child seems to have a much lower incidence of ADHD. Now, I could say tongue in cheek that maybe the Hispanic child has discovered cafe con leche earlier in their lives. There's actually research out there that's very old that says in Hispanic countries, the children are performing differently academically, and maybe the introduction of caffeine in the diet has changed that or has affected that. Who knows? Maybe because the Hispanic child isn't being seen in the healthcare setting as often as the English-speaking child. The lower socioeconomic children seem to have twice the risk of ADHD than the higher socioeconomically oriented children or located children. So there are socioeconomic factors that are affecting, there are cultural factors that affect the diagnosis of this condition as well. So let's get to the diagnosis. Attention deficit hyperactivity disorder. Now, I'm still of a mind that there's an ADD, an attention deficit disorder, and then there's a hyperactivity impulsivity component to it. And some kids present predominantly hyperactive and some kids present predominantly inattentive. There are 9 inattentive symptoms to have. If you have 6 or more of these before you're 16 years old, or if you have 5 or more at 17 or older as you head into adulthood, this can give you your diagnosis. It's very important to remember that, yes, you should have 6 or more below 16, 5 or more above 17. But these symptoms really should have been dominating and prevalent or at least observable before they were 12 years old. So like I said, the average kid, average age, 7 years old. I get a little on edge when I find out that an adult who's 25 years old is suddenly diagnosed with ADHD. And yes, they could have had it as a kid and they took it into their adulthood. I don't argue that. But if there were no signs or symptoms before they were 25 years old, then I'm a little more skeptical about the diagnosis. These symptoms should have presented in childhood, even if they went undiagnosed, okay, or untreated. So what are some of these symptoms? Often fails to give close attention to detail, makes careless mistakes in schoolwork and other aspects of work. Often has difficulty sustaining attention in task or play activities. As examples, they have difficulty focusing during lectures, conversations, lengthy readings, and they have difficulty with Zoom meetings. It is easier to zone out. It is easier to step away. And by the way, folks, no more complaints about the breakfast at FPA meetings. The breakfast is on you this morning. The food is on you. So no more complaints, okay? Not enough bagels, coffee, not the kind that you like. Go out and buy your favorite coffee for tomorrow morning or later today. It's on you. But that's what I'm talking about. Being able to sustain yourself in a lecture or a meeting for an extended period of time. These are examples of attention deficit possibilities. Okay, does not seem to listen when spoken to directly. My wife complains of this with me on a regular basis, that I'm not listening to her. I'm listening, I'm just very selectively listening. There's a difference. We all know about that. Guys more than girls know about this. Often does not follow through on instructions or fails to finish schoolwork. I am seeing some of these going on in my house right now with the kids, and again with this virtual training and education that they're in. Has difficulty with organizing tasks and activities, time management problems, okay, disorganized at the desk. These are some of the things that we might see as adults as well with the time management. Avoiding or is reluctant to engage in tasks that require sustained mental effort. I know I am. I'm definitely trying to avoid almost any sustained mental or physical effort, but that might be lazy, who knows. Often loses things necessary for these tasks. Your materials, hard to do your schoolwork if you lost your pencil or your pen or your book on a regular basis. Easily distracted. Easy to turn away now, easy to look at the television between your homework these days at the house for our virtual training and education. Okay, and then forgetfulness. Okay, now I sometimes will joke, and even tomorrow morning I'll probably joke about my forgetfulness and my dementia-like symptoms and such. I have a hard time remembering things, but I have a much harder time remembering something if I didn't pay attention to it the first time around. So once again, that attention to what you're doing in the moment at the time. Maybe when you think you're multitasking, and that's a good one. I'm impressed and a little skeptical of many people who say they are great at multitasking. In general, people are not great at multitasking. They can engage in more than one activity, but one of those activities is going to be sacrificed as far as your attention and how well you do that activity. Multitasking is a bit of a myth for most of us, but a lot of us like to think we can do it. Hyperactivity, well, this is a little bit more obvious. Fidgeting in your seat, making noises, squirming around, getting out of the seat during school or during meetings. Okay, when you're supposed to be remaining seated, you're not. Okay, runs about, climbs, gets maybe inappropriate activities. This is where it might even be a little bit more dangerous when they're running around and not paying attention to the world around them. They're tripping, they're climbing into a tree that's a little too high. They don't remember, they're not seeing the potential negative consequences of climbing that tree, like falling out of it and breaking an arm. So these kind of things sometimes get the children in trouble. They have a hard time simply sitting still and being quiet. They don't want to sit down and read a book. They need something to engage them physically oftentimes. They're on the go, they're driven. Now, talking excessively. Okay, you could say that many of our children might be talking excessively. I've noticed that again in these last few weeks, that the kids are in the house. They're supposed to be working on schoolwork, but they're looking for attention. And this is not negative. This is not pathological, wanting to engage with their parents and wanting to get into conversations and actually have a conversation with you, but you're busy with your Zoom meetings, or you're busy with something else or other activities if you're working out of the house, or if you have a different schedule than you used to have. And so some of these kids are actually trying to break in for our attention. Now, that might be a new thing. Don't assume that all of our kids have ADD or ADHD these past 6 weeks with our changed behaviors because of the pandemic. All right, they didn't just develop ADHD in the last 4 to 6 weeks. Okay, blurts out answers before the questions may have even been completed, difficulty of waiting in turns, and interruptions again. These are more of the hyperactive impulsivity symptoms. Now, as I said a little earlier at the beginning of these criteria, they must occur, well, at least 6 of the 9 symptoms before the age of 17, 5 of the 9 symptoms if it's after the age of 17. And as I said before, usually earlier in life. New onset ADD or ADHD, I'm looking for something else. It might be drug induced and maybe the wrong kind of drugs. There might be other things that we have to rule out before we go with this diagnosis of ADD or ADHD. And in our youth, these might be medications. The last 2 or 3 years, I've been talking about the vaping epidemic. Our kids are getting into the nicotine habits because they didn't recognize that nicotine was addictive, and they didn't recognize that they thought the vaping liquids were just flavored liquids. And it turns out they have high content nicotine as well. So we're not moving away from drug use, illicit or otherwise, with our adolescents, with our children. It's actually increasing because of the vaping problems. Hopefully we're getting a handle on that now that we've recognized that they were inappropriately marketing to the kids anyway. Okay. A couple of important things about diagnostics as well is that if it's just in the house, probably not ADHD. If it's not in the school setting or in another social setting, then, and this problems are only occurring in one singular setting, that might be something else to look into. So it's usually present in 2 or more different settings, like home and school. And important with almost all of our psychopathology, with almost all of our diagnostics, if it isn't interfering with the quality of life, with your social, academic, or occupational functioning, it's not a pathology. It's not a diagnosis per se. It has to have an interference. It has to have an impairment in your ability to engage socially, academically, occupationally. So if it's not causing trouble in those areas, it might be a symptom. It might be a noticeable thing to you, but you're functioning without treatment. It's hard to make that diagnosis. So it has to have an interference with our activities. So let's treat. Let's use medications because we're pharmacists and we like medications. So the cornerstone are psychostimulants. This is the methylphenidate and the amphetamines and a couple of other minor agents. The psychostimulants have been the cornerstone and have been the go-to first and second line treatments for, again, over 50 years. Now, they're important, and that's where we're going to go for most of our patients, but perhaps the patient is uniquely sensitive to these agents. Perhaps there's a comorbid medical condition that would prevent the use of some of these medications, and therefore we may be using non-stimulants or other medications with possibly different mechanisms of action, but these are our third line type agents. And some of our patients, some of our children, some of our adults are going to be on more than one medication as well. We might have combination treatments. So let's get to it. The stimulants have been the most frequently prescribed class of drugs to children and adolescents for decades. It has the largest body of literature in child psychiatry, belongs to the stimulants. So the data is there. There's no question about that evidence regarding the use of stimulants in child psychiatry for ADHD. There's a couple of subtle differences between the ages of diagnosis or approved indications. Dextroamphetamine actually is approved for kids 3 years and older. But when we look at drugs like methylphenidate, it's almost always 6 years and older. Occasionally you'll find a medication that's approved for children 5 and older. But the amphetamines, or in this case dextroamphetamine, is approved for children 3 and older, and methylphenidate is 6 and older. And we might clarify that a little bit later on as well. So you have the psychostimulant types, 2 major types: the methylphenidate group, which includes methylphenidate and dexmethylphenidate, the right-handed isomer version of methylphenidate, and the amphetamines. Now, mixed amphetamines or mixed amphetamine salts have been around for over 100 years. And we've been using them for ADHD, we've been using them for narcolepsy, we've been using them for weight loss for decades. So they've been around for a long time. We know them. That doesn't make them safer, doesn't make them easier to use, but we know them very well. They've been around almost 50 years longer than methylphenidate has. But methylphenidate is very popular, and we'll get to that in a little bit. Dextroamphetamine is the right-handed R or of the racemic mixture between levo and dextroamphetamine, which is what's in the mixed amphetamine salts. Dextroamphetamine is the right-handed version of that, the isomer. Liz dexamphetamine, I get a kick out of this drug because they changed the pH to an F to try to fool us. And now we have Liz dextroamphetamine, Liz being the lysine amino acid molecule attached to the dextroamphetamine molecule to give it a slightly delayed release effect, and we'll spend some more time on Vyvanse in a little bit. These drugs work. They work for attention. They help the ability to learn because they're improving focus. They improve academics for some individuals. They improve the peer interactions. They help normalize behavior. If you're doing better in school and you're doing better with social interactions, you're generally improving self-esteem and self-control. So these agents work for individuals with ADHD and ADD. Now, because of these profound effects, and we can go down another hour, if you like, on the off-label, and I believe in most cases, inappropriate use of the psychostimulants in high school and college students who don't have ADHD. But because they improve so many of these features, the academics, there's kind of an urban myth that these drugs would improve your grades and your studying and your performance, even if you don't have ADHD. That has a lot less data backing that up. But because these drugs work for the pathology, we often carry it into assuming that they will work for non-pathology as well. Now, methylphenidate, you know, is Ritalin, best of all. It has other names, of course, plenty of brand names actually, generics available. Ritalin's been out since the 50s. It actually, back in the 50s, might have been one of our first antidepressants. It was indicated for the treatment of depression for a few years before the antidepressants came out. So Ritalin is the common brand name of methylphenidate. Okay, it is the most prescribed of the psychostimulants still today, even though with all the newer brands, it's gotten real muddy. I would say methylphenidate is prescribed more than amphetamines, and we can debate whether that's good or bad or which one is better or not. Dexmethylphenidate is Focalin, and with a name like Focalin for focus, that makes sense. It's good branding right there. These two medications, methylphenidate, dexmethylphenidate, are dopamine and norepinephrine reuptake inhibitors. Now, if you increase dopamine too much, you might like it. And dopamine is our feel-good neurotransmitter, along with being important for cognition. So a strong dopamine reuptake inhibitor might have abuse potential. So our stimulants are usually C2 drugs with a black box warning for potential drug abuse and misuse. We're focusing mostly on dopamine and norepinephrine because we've seen actually some decreases in these neurochemistries, these neurotransmitters in scans for ADD and ADHD, kind of a brain hypoactivity. We would like to posit or theorize that it's mostly norepinephrine and dopamine, and again, maybe hypoactivity, okay? And low norepinephrine and dopamine gives us poor attention, poor focus, okay, poor cognitive skills in some cases, okay? And that is the mechanism. So it's a DNRI, a dopamine norepinephrine reuptake inhibitor. You can also call it an NDRI, norepinephrine dopamine reuptake inhibitor as well. But focus on that mechanism because it's a little bit different than the amphetamines. They have this mechanism and more. So there's a slight difference in mechanisms of action between methylphenidate and amphetamines. The dosing is usually start low and go slow, 2.5 to 5 milligrams a day. It rarely treats the problem. We usually have to go up. Back in the day when I was in training in the 80s, we used to target about 1 milligram per kilogram as a potential maximum dose for methylphenidate. And that's a little bit different than the about a 0.5 milligram per kilogram for the amphetamines. So 60 milligrams per day is a common maximum dose for the methylphenidate formulations. But some of the newer formulations with the differences in the well, how it's made, the sustained release formulation, the salts, sometimes the FDA wants you to give you what is the total weight of the drug, like 60 milligrams. Sometimes they break it down by what is the actual methylphenidate versus the salt or the base component, and therefore you might see smaller numbers for the methylphenidate that are in odd numbers like 3.8 milligrams or 4.7 milligrams. And that's trying to correct for removing the base or the salt that's involved. The immediate release usually only lasts a few hours. Now, when it first came out, this is why a bit of a stigma was created even in the 50s and 60s and 70s, because Timmy, who's my default name for a child with ADHD for some reason, Timmy was with ADHD treated with Ritalin when we only had the immediate release formulations. He was often the kid you saw standing in line at the nurse's station at lunchtime. So the medication would work for 3 or 4 hours, and come 12 o'clock, come lunchtime, they need to get dosed a second time. So the immediate releases are dosed 2 or 3 times a day. Even today, some folks are taking their immediate release early in the day, letting the extended release kick in later. Some folks are saying the extended release formulations are wearing off around 2 or 3 or 4 o'clock, which is the time school's supposed to be ending anyway. But I've had consults and I've seen some individuals receive an immediate release formulation so they could do their homework. So maybe they would take it at 3 o'clock or 4 o'clock in the day, get another 3 or 4 hours of focus to finish their homework and their projects. And then hopefully, it would not negatively impact their appetite for dinner or their sleep behaviors, because some of these agents can obviously cause insomnia as well. Now, because the immediate release formulations did not sustain for an entire day, and because Timmy didn't want to be seen standing in line in front of the nurse, the sustained release or extended release formulations obviously became popular. Side effects. Anorexia, as I said before, take it with food, don't take it before the meals, because they may not want to eat their meals if you give it to them too soon before the meal. Insomnia, nervousness. It's kind of like these drugs can turn on the fight or flight response. So increasing norepinephrine makes people generally nervous and anxious. You might have some, again, anorexia could be also considered a GI distress, but perhaps some diarrhea or constipation. Perhaps some nausea can occur. Now, tics might be more problematic in individuals. These could be vocal tics or motor tics. That doesn't mean they have Tourette's, but it means that this could be a problem. Again, we're back to social interactions. If the child is trying to interact with their peers or others and motor or vocal tics are obvious, then that could cause a kind of a social anxiety and an avoidance of interactions. So tics could be something that we might be able to address. If a tic is a side effect of the stimulant, like methylphenidate or the amphetamines, this might be a place where we add clonidine to manage the tics associated with the stimulant. We overdid it. Maybe we could back off on the dose. I'd much rather us back off on the dose to manage a side effect than to add another drug to manage a side effect. Emotional lability. Okay, emotional lability is very important as well. And let me see here. Long bone growth suppression. These are still issues that we have seen. Long bone growth suppression. This is why we still give drug holidays to some of the children. Maybe the child was genetically designed to be from, let's say, age 10 to 11 years old to grow 4 inches in 1 year. But during the school year, they were on Ritalin, they were on Adderall, one of these medications. And over the course of the 9 months in the school year, they've only grown 1 inch. And therefore, there's some growth suppression occurring. This is why in the summertime, we would give a holiday. And oftentimes, the child catches up. The child gains 2-3 inches in 2 or 3 months, which can be painful. There could be bone pain with regards to that as well. Increases in blood pressure, also a possibility. Headache, and in my world, psychoses can still occur. We theorize that the primary reason for psychotic symptoms like hallucinations and paranoia is due to too much dopamine. Now, I am going to take just a brief second to look at the chat to see if any questions have come in. I'm having to maneuver a little bit here. I apologize for that. I'm trying to find.
Okay, Dr. Ray, this is Michael Jackson.
Hey.
There is a raised hand in the chat from one of our participants. I have the ability to push a button and allow them to talk, so I'm going to do that. for Janice Rodgers. You are unmuted.
Okay, go ahead, Janice. Go ahead and ask your question.
Okay, her device might be muted. I have another raised hand from Erica. So I will unmute Erica. You may now ask your question.
Hello.
Hello, Erica. Go ahead. I see that you're muted, but let's unmute Erica and see what the question is.
Hi, can you hear me?
Yes, I can. Go ahead.
Good morning. I was trying to find out, for the children that are on the drug holidays, are you finding that they're having better response when they do put them back on the medications because they're having like a drug holiday during the summertime?
Oh, that's a wonderful question. Sometimes we get a bit of a tachyphylaxis and it seems like the drug doesn't work as well as it used to. And I've noticed the very same thing. Sometimes when we have a drug holiday, remember that they had a year, hopefully, or at least an academic year on the medication, and they learned things and their behaviors improved. We find that, I'm not going to say you grow out of ADHD, but some people do seem to get better with time. And perhaps it was from the academic and occupational and educational or even behavioral interventions that were also being done with the child during that year, the therapy that was being done. So sometimes when we give them the drug holiday and then it's time to go back to school, they don't need the same dose, or perhaps they don't seem to need it as much, or perhaps they are simply better with a better response because, my goodness, the therapies worked, the behavioral, the cognitive, the other interventions that you're getting from your therapist also had a more lasting improvement and impact. So I've noticed the same thing. Sometimes we give a drug holiday for that summer, maybe something good things happened between the therapy that they received, between the habits or behaviors that they got into, then maybe they don't need as much drug because when we give them the same dose, the same time, they seem to have a very profound response. So I have noticed sometimes that our children, or even our adults, but mostly our children, don't need the drug again. They almost get better without it, or they got better with it and therefore don't need as much of it. So the short answer is yes. That's a wonderful question. It can change after a drug holiday. All right, good questions. All right, I'm going to let you keep screening for me, Mr. Jackson, and as I move on toward the slides again. Let's see.
Very well.
No, I didn't stop sharing, so let's get to full screen. There we go. All right, so our slow release or extended release formulations. Again, many of us as pharmacists have seen Ritalin and Metadate and Methylene back in the 70s and 80s and such. Now, a drug that came out about 5 years ago, Aptenzio XR. If you have a copy of the handout, this might have been something I added later. And don't worry about it. Aptenzio is just another brand name of extended release methylphenidate. The dosing is the same, 10 to 60 milligrams. And that really hasn't changed at all. The 10 to 60 milligram is a common dose that we see for methylphenidate. It's meant to last during that school day or during our working hours for 8 to 10 hours, 8 to 12 hours if we're lucky. Now, Daytrana is our only transdermal patch for ADHD, and it's a methylphenidate patch. And that's good to see if the child doesn't want to take the pills. If the person doesn't want to be seen taking pills, we do have a patch called Daytrana. Now, some products that came out in the last few years, maybe some of you have seen this. This was our first, and it may still be our only suspension or liquid extended release methylphenidate. The drug is called Quillavant. Again, more power to the formulation folks for developing a sustained release or extended release liquid. So the beads and the formulation allows for an all day, or I wouldn't say all day, but 8 to 10, 8 to 12 hour duration of action. So Quillavant XR is a suspension. And a little later, just a couple of years ago, they came out with QuillyChew. So there's a chewable tablet that is still the extended release formulation that we saw with Quillavant. So again, look at these doses, very similar, 20, 30, 40 milligrams. Start around 20 milligrams. So if 10 milligrams is a good immediate release, so 2.5, 5, 10 milligrams is a good IR dose to get started, our extended release formulations would make sense that they're usually in the 20, 30, 40 milligram range, because the 20 milligrams is meant to be 10 milligrams twice a day. 60 milligrams would be equivalent to 30 milligrams of the immediate release twice a day. So Quillavant and QuillyChew are two of our newest formulations. If you want to say a couple of years old is newest. Now, Focalin came out, and it's already generically available as far as I know. Focalin came out probably 15 years ago or so, and it is the dextro or right-handed isomer version of methylphenidate. If methylphenidate is levo and dextroamphetamine mixed, a racemic mixture, they took the low-hanging fruit of drug development. They identified dextroamphetamine, determined that it had efficacy. That's all they had to do. And the FDA blesses them with a new drug patent and FDA approval. So dexmethylphenidate, and again, it's very similar to the difference between Adderall and Dexedrine. Adderall, or the amphetamines that are levo and dextro racemic mixtures, versus dextroamphetamine being the right-handed version of amphetamines. So some individuals are on Focalin or Focalin XR. Now, they might take Focalin XR for school during the day, and I've seen some kids get a low dose of Focalin immediate release in the afternoon for homework. Okay, so these treatments are very individualized. There's no one size fits all with any of our conditions, but even in ADD or ADHD, there is no one size fits all, and we tend to titrate and individualize. Maybe the kid does great if they get it at 7 a.m., but not at 6 a.m. Maybe they need to take it 30 minutes before school. Maybe they can take it as they're walking out the door to school. So this timing is a very important thing that is individualized for our patients. The Focalin XR is designed to mimic the immediate release twice a day. So you can see there's even like two peaks in this particular kinetic drug concentration type profile. So many of our extended release formulations, they might have a biphasic release. They might have an immediate release quality to them, something on an outer coat of the resin or the bead, and they have the immediate release that occurs within 30 minutes to an hour. And then they have a secondary biphasic second release that might occur 6 to 8 hours later. Concerta really wrote the book. Janssen and the company that developed the Oros technology, taking methylphenidate, and they put this in a triphasic release formulation. Concerta is still out there. Now, there are generic variations of Concerta now, but Concerta really enjoyed a very long time on the market of a protected brand, because though extended release methylphenidate was nothing new, it was really hard to duplicate the Oros release technology system. So they had an unusually long life of just brandability beyond their patent because of the formulation itself. So, but look at these weird doses: 18 milligrams to start, 54 milligrams maximum. And there were guidelines in the package inserts to convert if you wanted to. And it was designed to have 3 releases, literally an outer coat on the capsule. And it was more like a caplet. It was a semi-permeable membrane caplet that allowed water to come into it. And then there was a push compartment, a non-active ingredient that would expand when water was exposed to it. And then it would push the drug out 2 laser drilled holes out one end of the caplet. And therefore, if you were to sometimes, if you were obsessive this way, and check the stools of children that took Concerta, you might see what looked like an undissolved caplet. And this might cause some parents a little concern, and they may have come to us as pharmacists and say, the tablet is not being absorbed. I'm seeing it in a bowel movement after they go to the bathroom. It turned out that the drug was inside the caplet and pushed out of two compartments. And that push actually has two phases. So you had the immediate release, fast dissolve, that was outer coating. And then you had two phases of basically the drug being pushed out of drilled holes, laser drilled holes of the caplet. And that's why it had a triphasic release characteristic. Very interesting. Now, our newest methylphenidate formulation that came out about a year and a half ago, give or take, as far as formulation availability and such. And maybe you've seen this advertised already, Jornay PM, extended release. For those of us who just can't get the energy to wake up in the morning and take our immediate release methylphenidate, this medication is meant to be taken at nighttime. Can you believe it? We've pushed it forward, not even to the morning, but we've pushed it to the night before. So this medication does not have an outer layer per se, because it would keep you awake. You couldn't go to sleep. But it has, its outer layer is not drug. Its outer layer is kind of a protective barrier that will take a few hours to dissolve and then start the release process. Mr. Jackson, could you see about muting everybody? I'm getting a couple of folks that I'm hearing background noise on there. There you go. Very good. Thank you.
Take care of it for you. Thanks.
No worries. So back to this. Take the medication at nighttime between 6:30 and 9:30. Don't chew it, because that could break the matrix of the outer coating, for instance, and release the drug early. You can even open it up and sprinkle it into applesauce. So these are beads that have the coating on them. And the advertisement is interesting. Mornings set the tone for the day. And Jornay isn't just for kids. In fact, it's indicated for people with ADHD aged 6 and older. And as we all know, adults with ADHD know all too well that ADHD can make mornings challenging, and all-day control is important too. Now, I just pulled that right off the website as an advertisement, because this speaks to another thing that I've observed in the last couple of years. These medications are getting FDA approved with child and adolescent studies, kids age 6 to 17 years old. Sometimes a study with kids only age 6 to 12 years old. And look how it's worded. And so they've somehow gotten around adult studies. If you go to the Jornay package insert, you won't see adult studies reported. You'll see the child and adolescent study reported. So now they've changed the wording. They've gotten the FDA to allow this wording: ADHD aged 6 and older. So there's an inference that it would work in adults. And this drug is a great example where I didn't see an adult study, but they're saying adults struggle with ADHD and treatment is important as well. That is a huge inference that it would work in adults. So some of these new products, because methylphenidate is approved in adults as well in certain formulations and such, because they did a study with kids 6 and older, they are inferring that this drug would work with adults. So keep that in mind. They're changing some of the wording. It used to be child and adolescent. It used to be 6 to 12. It used to be 6 to 17. Some of the newer agents are simply saying 6 and older. And a 26-year-old is older than a 6-year-old. So they're inferring adult indications. All right, I kind of gave you this example verbally. A microbead with a layer that essentially prevents medication release. It'll break down. It keeps the medicine from working. So it's going to take about 12 hours. And then when you wake up at 6:30, 7:30 in the morning, whenever, now the drug is being released. You're going to wake up with a great start, apparently, because you've got methylphenidate in your system upon awakening. Okay. And that is where the medication is coming from after an outer layer was dissolved, if you will. It works. It works. And again, this was a study in children 6 to 12 years old, and it was better than placebo at reducing what we call the SCAMP. There's an ADHD rating scale, which I'm far more familiar with, but I've noticed in some newer research, the Swanson, Kotkin, Adler, Imflin, Pelham scale, we just call it SCAMP, and SCAMP kind of relates nicely to children, those scamps. They're scampering around. So this is a 13-item teacher-rated scale that assesses ADHD in the classroom setting. This study with kids, look at the numbers, about 53 on placebo, 64 on drug. The drug was statistically superior to placebo. By the way, placebo still works every once in a while, but it beat placebo, so it gets FDA approval. And this is what I found in this package insert. I didn't find an adult study that used the SCAMP scale. Let's switch gears to the amphetamines while we have some time. Looks like we're pushing on 8 o'clock right now, and I've probably slowed up with my comments and such. I'm going to speed a couple of things up and move through some stuff that should be old hat for us. Amphetamines should be old hat for us. We've had dextroamphetamine and regular amphetamine or racemic mixture amphetamine or amphetamine salt, mixed amphetamine salts. We've had them around for 50 plus years. Nothing has changed in that regard. Their mechanisms is that they also are norepinephrine and dopamine reuptake inhibitors, but they can also enhance the release of norepinephrine and dopamine, and that's a separate mechanism. And amphetamines actually have weak monoamine oxidase inhibiting qualities. They have more ways. They have 3 separate mechanisms to increase the neurotransmitters. Does that make them better? Not necessarily. There's very little data that would suggest that amphetamines are superior to methylphenidate. But there are differences. If you are a methylphenidate responder, you might not be a dextroamphetamine responder. If you're an amphetamine responder, you might not be a methylphenidate responder. So those are why they're in the first and second line treatments. And the side effect profiles may be a little different as well. Maybe one of the stimulants is better tolerated than the other stimulant in those side effects that we talked about. Dexedrine, start low, go slow. Starting up 2.5 milligrams, going to 40 milligrams. FDA approved in 3 years and older, immediate release. The Dexedrine Spancel came out, and it was the kind of an IR. It was meant to be a sustained release formulation, and we could break the capsule open and guess what? Mix it with applesauce. A lot of these drugs love applesauce. Zinzeti is dextroamphetamine. Enough said, another brand of dextroamphetamine. Procentra is a bubblegum flavored oral solution of dextroamphetamine. So brands, formulations, liquids, these are just old wine in new bottles, folks. Adderall, which came onto the market hard in 94, 95. By the way, Adderall was the old Obitrol of the 50s, 60s, 70s, 80s, and early 90s. They just changed the drug Obitrol for weight loss. They renamed it Adderall, ADD for all people, and voila, you have the hottest thing around in the 90s and such. Adderall comes in an XR formulation. It's mixed amphetamine salts, a very old formulation, a very old racemic mixture. The salts are sulfate, succinate, aspartate, but it's basically levo and dextroamphetamine. But wonderful marketing, wonderful branding, especially when they just changed the name of Obitrol to Adderall, and they didn't even change the formulation, just changed the color of the pill a little bit as well. I think it went from an orange to a blue or vice versa. Adzenys or Adzenys ER, so an extended release formulation. Now, it comes as a suspension. It comes in an orally disintegrating tablet formulation. Some of us may have seen this being dispensed. Now, this name, My Day Is, I think it's very interesting. It's indicated for adults, for more power to them for getting it. The advertisement has a lot of the advertisement focused on women. focused on women, recognizing that women can suffer from ADD and ADHD as well. It is extended release mixed amphetamine salts. That's what it is. It's an extended release formulation, but they're going after adults who are having bad days. So now you can say, my day is going better. Evekio ODT, immediate release formulations of amphetamine sulfate, both the dextro and the levo isomers, ages 3 to 17 years. Now, Dianavil was our first extended release oral suspension, okay? And I believe Dianavil is coming from the same people that brought us the Quillavant and Quilichus. I think that's Tris Pharmaceuticals. We have 2.5 milligrams, a higher dose up to 20 milligrams. Now, this is, again, another example that when I was looking at their package insert, is it indicated for adults? It wasn't approved based on adult research, but their indication says ages 6 years and older, which infers that an adult could use it as well. So this changing of the wording on the indications, somebody started doing it a few years ago, and it's definitely taken off. Here is another example of a study, and when they were looking at the ADHD rating scale, the SCAMP, I'm sorry, they did this research in both groups. The SCAMP combined scores, we see that the drug is superior, lower scores or better reduction in the ADHD symptoms compared to placebo, which didn't seem to really touch the ADHD symptoms. Now, Adderall, again, like other amphetamines, has or could have its problems. Back about 20 years ago, we had a series of deaths, and Adderall was really close to getting pulled from the market for a while. Canada pulled it for a little bit, for a few months. FDA did some more digging. And this is a great example, and another time for me to warn you that just because Timmy is 6 years old and looks great and loves to run around and play, doesn't mean that Timmy might not have an underlying problem, a congenital heart defect that we're just simply unaware. So there, you hear these cases of kids who are playing sports and then they die on the field. It's horrible. They were doing the same thing they've been doing for months or for years. But oftentimes these kids who are using these medications and playing sports, going through rigorous exercise, they may have an underlying problem, hypertension, aneurysm, that has gone undiagnosed, unrecognized. Children still need a good medical workup before they're given these medications. Vyvanse, the only word about this is that, yes, it's dextroamphetamine. It might have a lower abuse potential. At least that's actually how it's helped being marketed. Why is it potentially have a lower abuse potential? Well, extended release formulations have that delayed response to some people. The faster the response, sometimes the more reinforcing, even psychologically reinforcing a drug can be. And this delayed response is one way to have less abuse potential. The other way is that if you were to adulter the product and maybe liquefy it and shoot it up as an IV drug abuser might, well, it won't work as well because that lysine amino acid is attached to the dextroamphetamine, essentially rendering it less active. And then when we swallow the capsule, our body cleaves off the lysine amino acid the way it breaks up meat or breaks up protein, and it kind of releases the dextroamphetamine that way. So if you were to inject Vyvanse, you wouldn't get as high as you would normally get from dextroamphetamine because the lysine amino acid wasn't broken off from the molecule because those enzymes are in your stomach, they're not in your blood. So when they've done studies looking at the abuse potential for Vyvanse, it looks like it has less abuse potential, at least the lower doses, 50 to 100 milligrams, has less abuse potential than diethylpropion or dextroamphetamine. Now, when you get to bigger doses, a lot of drug has abuse potential. So this helps get the drug into its kind of niche of promoting itself to have less abuse potential. And it might affect and have a lower risk for things like high blood pressure, but it can still raise blood pressure just more than placebo, but it might have a lower effect and therefore it might help tolerability in some patients. Now, I'm going to move quickly through biological etiologies, pathophysiologies. Yes, it looks biological. For years, we've seen that some indicators for brain volume in this study, a genetic study looking at dopamine transporters, we almost found a way to preferentially determine if a kid was going to be a good responder to methylphenidate based on their allele, the 9/9, the 9/10, or the 10/10 allele with the dopamine transporter. If you had the 9/10 or the 10/10, you were a great responder to methylphenidate. If you were just the 9/9 short type, you didn't have a very good response to methylphenidate. This is hard to replicate, though. If this was solid information, then we would all be doing genetic testing on these kids, and we're not doing that yet. All right, this study right here says that children with ADHD have a lower brain volume than active controls without ADHD. So the red line would be controls and the blue line would be ADHD symptoms. Now, sometimes if you were to also look at this chart, this little scale right here, this graph, I'm sorry, you might say to yourself, well, that's weird. It looks like males have a greater brain volume than females. Make no mistake, I am not saying that males are smarter and have bigger brains than females. If they do, they're not very efficient with them. Women apparently can do more with less than males can. So it is interesting that the brain volume study is side by side, and males seem to have greater brain volume than females, but there is no indication that, that males are smarter than females. Just ask my wife about me. Okay, moving on. Let's do a little knowledge check here. Just to make sure that we remembered a couple of things I said. Which of the following medications is available as an extended release formulation? So, and a suspension at that. Is it MyDay is it Evekio? Is it Dianavil? Or is it Daytrana? Or C is the caffeine in my coffee has not kicked in. All right. Okay, it looks like we get, I don't see the chat. If people wanted to just type in on their chat. Let's see here. I'm getting a lot of A's. I'm getting some C's. Dianavil spelled out. C's. The predominant answer is C. Well done. C is the suspension. Daytrana is the patch. Daytrana is the patch. Okay. And MyDay is an extended release formulation. But Dianavil is the suspension. It's an ER suspension. And Daytrana is the patch. Well done. Well done, folks. Good job. Okay, control yourselves. Let's move on to the next one. Let's see here. Get to the slides again. Okay, non-stimulant meds. All right. Oh, timing. I tell you what, when I get on a roll, I really use up the time. I needed about 3 hours. So our non-stimulant meds are Strattera, a norepinephrine reuptake inhibitor. Bupropion is off-label use, but it's an NDRI. Clonidine and guanfacine are old wine in new bottles. Change the name from Catapres to Capve or 10X to Intuniv. They're still alpha agonist. They can reduce the norepinephrine release, and therefore they decrease norepinephrine, which doesn't sound like a good idea for ADD. And I don't think they're a good idea as primary treatments. They're better for the hyperactivity impulse control problems that some individuals have, and if they had a side effect like tics to the stimulants. And back in the day, the tricyclics, especially dazipramine, was a second-line agent as well. So I'm going to kind of move through this because I wanted to say a few things about autism before we break at 8:30. So Strattera, been out now for 20 plus years, still considered a second line agent. Now, I know some people, because of their concern, many parents might approach me with a concern about addiction, being on a strong drug, my kid being on amphetamines, my kid being on Ritalin. Maybe they'll go to Strattera as a first-line agent because of concerns or stigma associated with the stimulants. But head-to-head, a stimulant like amphetamines or methylphenidate would be better than Strattera, atomoxetine in a head-to-head trial. Clonidine, I've mentioned what they are. Available as a patch, by the way. The patch is not approved for ADHD, but there is a patch if you were to use it off-label for ADHD. We were using clonidine in the 80s to help some individuals with hyperactivity. And it is better for the hyperactivity symptoms than it is for the cognitive attention deficit symptoms. Brand name changed. I think it's interesting. They didn't even change the dosing. Even though Capvey is an extended release tablet, it's still a twice-a-day drug. They didn't even get away from twice-a-day dosing with clonidine when they went to Capvey. It's still dosed twice a day, even though they say it's an extended release tablet. Guanfacine was sometimes more popular than clonidine because they thought it was a little bit better tolerated than clonidine, and it was given once a day. But changing the formulation to Intuniv, an extended release formulation, didn't really change the fact that you could use generic guanfacine once a day or Intuniv once a day. Side effects, we know very well as pharmacists, so be mindful of the blood pressure effects that can cause with drugs that were meant to lower blood pressure. So orthostasis and syncope and low blood pressure is a possibility, and they're generally sedating drugs. We might give these agents at nighttime to some of the kids who are having trouble with their behaviors in the evenings, because if we gave them the stimulant, they would be awake all night, things like that. And many side effects like somnolence you can become tolerant to. Bupropion, it would be an off-label use. Bupropion is not approved for ADD or ADHD, but it is used oftentimes in adults with ADD or ADHD because it might not be the red flag. It might not send the message that the individual is dealing with ADD or ADHD. They could use Wellbutrin and people would just assume maybe depression or smoking cessation or weight loss or something else if it was combined with naltrexone. So Wellbutrin is being used off-label for about 25 years for ADD, ADHD, and again, mostly in adults, though it is off-label. Has its own concerns, which we know as pharmacists. A lot of comorbidities with ADD and ADHD. Conduct disorders, anxiety, oppositional, Tourette's, depression. Learning makes sense. So you'll see a lot of combined diagnoses, dual diagnoses, comorbid diagnoses. And does the ADHD cause the problem, or is ADHD just part of the problem? Or is there another problem, like a learning disorder, which makes the child look like they have ADD? So these are the issues that I struggle with sometimes. If I give some children, maybe because they were inappropriately diagnosed with ADD and they don't have it, but they're given a stimulant, well, that stimulant should give them anxiety, okay? It should give them an energy they may not need and we may not want to see in them. So we have to be very careful with our diagnoses if we're going to do it right. So the general guidelines, let's wrap it up here and summarize. Stimulants are still first line. And again, if you use methylphenidate and it doesn't work, then you try amphetamine. If you decide to use amphetamines first and it doesn't work, then you try methylphenidate. So they are both first and second line treatments. If those two treatments, those two groups don't work well for you, then you move on to something else. And maybe the reason why you did that is because you were worried about substance abuse, or you're worried about a certain side effect like tics or blood pressure or sleep. These kind of things might move us into the direction of a non-stimulant, okay? Please be careful when we're stopping drugs suddenly. I said drug holidays with stimulants. We can still have a kind of a crash and might even have some depressive symptoms when we suddenly stop these agents and other problems. If we stop the clonidine and guanfacine suddenly, thinking that we needed to give a drug holiday with these drugs, we could have rebound hypertension. Drug holidays we addressed already, and we have a lot of new agents that we can still put in applesauce. Try not to give these drugs at nighttime. Again, these are fairly basic and self-explanatory. I'm going to now, I've already verbalized the high rate of response. Another question, another knowledge check. We have, which medication is not FDA approved for the treatment of ADD, ADHD? Go ahead in your chat. Is it Jornay? I think I misspelled that. Should be an R. Jornay, which is methylphenidate, a version of it. Is it Dexedrine? Is it Capvey? Or is it Wellbutrin? All right. Now, I want to see 100% on this. All right. I emphasize the heck out of that. It's an NDRI. You guys could start messing with me right now if you went with another answer. Okay. Moving on. Now, autism, I could spend an hour on it, but it's a short presentation because there's 2 drugs FDA approved for autism. Everything else is off-label. Now, individuals with autism have had trouble these last few years adjusting to not being allowed to be called Asperger's anymore. Whenever you heard the term Asperger's was kind of a variant, sometimes considered high-functioning autism, but they held on to that label because it was Asperger's, it wasn't autism. But with the DSM-5 coming out about 7-8 years ago now, they did away with the Asperger's diagnosis. Now you're just high-functioning autism. You might be cognitively very competent, very good. You might be a genius. You might be Sheldon on Big Bang Theory, but you still had some social skill problems, that sort of thing. So now Sheldon, when Big Bang Theory started, was Asperger's probably. Now he's high-functioning autism. So some individuals still had problems letting go or haven't let go of that label for Asperger's. So autism is social skill problems, interaction problems, communication skill problems. And then what sometimes gets them into trouble are the irritability and aggression that might occur when they have difficulty with communicating. They also might demonstrate or have behaviors of repeated restricted patterns that makes them look like they might have obsessive compulsive disorder, the way they have certain need for sameness, certain need for order, the way they treat their toys, the way they spend time on a certain toy. The children have these restricted patterns of behavior that give them some apparent comorbid obsessive compulsive type symptoms. Autism has a high comorbidity with epilepsy and seizure disorders as well. Now, the criteria is basically persistent problems with social interaction and social communication. Again, in different contexts, different settings, and restricted repetitive behaviors, interests, and activities. These are our 2 big criteria. All right, they have these problems, okay? And I'll let you read them at your own time. They must be seen early. You can't go your whole childhood without being autistic and then as an adult become autistic. There's something else going on if that is the case. Maybe something like schizophrenia could explain some of the changes in behaviors and communication problems and patterns and interest in activities. Okay. So possible causes, I do not know the answer. Genetics, I think, are involved. SNPs, polynuclear variants. So we are seeing some mutations. There's a lot of genes that seem to be related without being absolutely the cause. It might be clusters of genes that are involved, this aspect of epigenetics. Now, I'm a big fan of the theories that genetics loads the gun and the environment pulls the trigger. So exposure to chemicals during pregnancy in utero, exposure to the vaccines was a popular theory, obviously in the 80s and 90s, which doesn't hold water anymore. It's been refuted. The data's out there. Vaccines don't cause autism because we changed the vaccines. We changed the thimerosal that was in them. We changed the amount, or we took it away. We changed the vaccines in response to the possibility of autism, and the incidence of autism keeps going up. So the vaccines aren't it. Now, could vaccines trigger an autoimmune response? Maybe. Could vaccines be a part of the picture? There's no data to say so. Drug exposure. For a long time, there's been this controversy about SSRI exposure. A pregnant woman taking SSRIs during pregnancy or just before pregnancy, and children having a higher risk for autism. That has been refuted in quality papers in the New England Journal of Medicine. But there's still controversy around that because autistic individuals may have trouble with serotonin, which explains some of their impulse control, stereotypic behavior problems as well. So we don't know the cause of autism. So what do we do with autism? We treat it, but we treat it symptomatically. We do a lot of things to help treat it. I want you to consider medications as a last line treatment. Behavioral, educational, occupational, speech, language. You can modify diets if you want to try. It may or may not help. You can try alternative medicine and dietary supplements. There's no magic bullet. There's no perfect treatment. Children with autism are a variation. There's no one type of autism. If there's multiple genes, there could be multiple types. One problem might dominate over another. Medications are symptomatic treatment. There is not going to be a cure for autism. We don't have a cure for ADD and ADHD. So the medications are generally, and this is how I approach it, the medications are there to manage symptoms that are interfering with the child's ability to engage and fully benefit from the non-pharmacological interventions, like the behavioral interventions, the applied behavior analysis, the education, the occupational therapies and speech language. If the child is irritable, if the child is aggressive or combative and cannot engage in these treatments because of that, that's where we might pick a medication. It's good and bad that we have medications, but look at the two medications that are FDA approved, risperidone and aripiprazole. Two antipsychotics are the only two drugs approved for children with autism, okay? Could other treatments be used? Absolutely. There's a lot of off-label use of medications in autism. The SSRIs might help the symptoms that look like they have like obsessive compulsive disorder. The alpha agonist might help aggressiveness and irritability. Naltrexone has been tried since the 80s. Psychostimulants, if there's this biggest problem with attention and learning and hyperactivity, maybe a psychostimulant would be used as well to treat that symptom associated with the autism. Do the drugs for dementia help the cognitive problems associated with autism? We've tried them. Anticonvulsants, yes, there's a high incidence of seizures and epilepsy with autism, but anticonvulsants might treat aggression and impulse control problems. So the antipsychotics are specifically effective for irritability, aggression, some stereotypic behaviors, and hyperactivity. We know that would work. We have risperidone as the first drug in 2005 approved. It was superior to placebo in reducing irritability in children with autism, okay? It improved global ratings, not just irritability, but other aspects, like I said, other symptoms. It was improving the symptoms in 75% of the patients versus placebo helping 11% of the patients. All right, it works. You still have weight gain and drowsiness as a side effect, potentially extrapyramidal symptoms if we give too much of the drug. Start low, go slow, 0.25, 0.5 milligrams, and titrate up. The weight gain might be more problematic. Granted, these are kids and they might have diet issues already. Sometimes they're very picky eaters. Sometimes we want the kid to eat more. But weight gain in a child is normal. They're a moving target, but do your very best to monitor for these issues. Prolactin elevation is a problem with risperidone and many antipsychotics. This would be watched. There was an initial increase and then it went down over time. So side effects related to hyperprolactinemia could be gynecomastia, galactorrhea, decreased libido, which I'm not too worried about in a 5-year-old or a 10-year-old, but yeah, growing breast and having other problems secondary to that sort of thing could be socially stigmatizing and problematic if the kid is trying to improve socialization. So be careful with that. Abilify has less of an effect on prolactin, less hyperprolactinemia, does have some akathisia. Now, akathisia looks like restlessness. And now are we going to say, I give the kid Abilify for autism? Now I see a lot of restlessness. Now I'm going to give them a stimulant for the restlessness because it looks like hyperactivity. So be careful that we sometimes fall into that trap of treating one drug side effect with another drug and it snowballs on us. It was better than placebo at reducing symptoms of attention and hyperactivity. Okay, it improved irritability secondary to autism, better than placebo. I'm not surprised by any of this data. Haloperidol would work for our patients as well. Okay. Now, again, same target symptoms. I'm going to move, the SSRIs are not approved, but they might help the OCD symptoms. Fluvoxamine, fluoxetine has been shown to have some data, but not FDA approved. The acetylcholinesterase inhibitors, you got to really want to use these agents. Only a couple of studies, and these are case reports, open label, no good placebo-controlled trials. Alpha agonist, again, maybe helps irritability and hyperactivity. Now, psychostimulants, methylphenidate looks better than the amphetamines. The data for amphetamines, now going back into the 70s and 80s even, the amphetamines might worsen the symptoms. Methylphenidate, for whatever reason, maybe it's a milder version of the mechanisms, the effects on norepinephrine and dopamine, might be the preferred stimulant over amphetamines for most of our children. I'm going to bring you to this treatment algorithm. This treatment algorithm is something that has been published in the pediatric pharmacotherapy textbook in the chapter on autism. And I would choose the medication based on the target symptom. Irritability, aggressiveness, yes, an antipsychotic. Attention deficit, methylphenidate. Stereotypic behaviors, back to antipsychotics like risperidone and aripiprazole. Anxiety, depression, OCD symptoms, maybe an SSRI. Self-injurious behavior, back to an atypical antipsychotic. And if those drugs that I put at first line don't work, then we switch. And why do we switch? Inadequate response or intolerable side effects. So this treatment algorithm is in that chapter and in these slides for your use. And then I back it up with the quality of the data that has been studied and published regarding the efficacy of these agents for these problems. And I put that in a table format for you regarding the potential areas of autism. Last knowledge check before we stop. Which of the following medications is or are FDA approved for the treatment of autism spectrum disorder? Seroquel, popular antipsychotic. Ritalin, popular stimulant. Risperdal, atypical antipsychotic. Naltrexone, Revia. Prozac, fluoxetine. All agents we have seen in the treatment of autism. What does our magic chat say? Let's see here. Our magic chat says, ooh, we're all over the place. We're some B's and some C's. Mostly C's, which is a good thing. All right, I like that. I've seen a lot of C's, good deal. All right, B and C. Ritalin is popular, but not FDA approved for autism. FDA approved for ADHD, and if they have the comorbid diagnosis, then I feel better about the Ritalin. Risperdal is the go-to FDA approved drug for autism if you're not going to use Abilify, which is the other go-to agent. Folks, it's an hour and a half just zooms on by, and I do appreciate your time and attention and your interactivity with the questions. Oh, how do the stimulants work on the child brain? I've kind of answered this. They increase norepinephrine and dopamine. Is it different than the adult brain? No. We used to call these kids, say these kids had minimal brain dysfunction, but we are jacking up norepinephrine and dopamine in both the child and the adult's brain. Is there an age where I try to stop or get people off of stimulants? Yes. It turns out I would try to stop a stimulant in an adolescent, a teenager. They may have benefited, and I hope to God that they have been receiving cognitive, behavior, educational, occupational interventions, as well as their medications for their ADD, ADHD. There used to be the myth that everybody grew out of their ADHD when they went to adulthood. That is not true. In adulthood, we discover coffee and cigarettes, and many adults were self-medicating with nicotine and caffeine to treat their symptoms of ADD. Now, as we go into adulthood, we become less hyperactive, but we don't lose the attention deficit problem. Are there concerns for addiction? Yes, there are concerns, but here's a different way to look at it. if we don't treat the child and adolescent that does have ADD or ADHD with appropriate treatments, then their risk of addiction to inappropriate street drugs goes up because they are looking for something. They're self-medicating. If you can't get a hold of methylphenidate or Adderall, well, then cocaine is a great alternative. Cocaine is a norepinephrine, dopamine, serotonin reuptake inhibitor. So sometimes if the child with ADHD goes untreated, they have an increased risk of problems with the law, an increased risk of problems with drug use, inappropriate drug use, because they kind of self-medicated themselves in that direction. I'm going to go ahead and stop there to make sure that we stay on time and open it up to Mr. Jackson and Tien if there's any codes or other information we have to send the audience. Thank you very much for your time and attention today, folks. I do appreciate it.
Thank you, Dr. Ray, for that awesome presentation.
I use my applause app for you, Dr. Ray.
You're very sweet. I always feel rushed in the end. I just get on my soapbox about certain things.
Absolutely, and thank you for being there. And while Dr. Marin is getting ready to transition us to the next presenter, we have over 267 folks that are registered in this webinar for us today, and thank you for being with us. We have folks here from New Mexico, from Orland, Maine, Brentwood, Tennessee, from New York, from Roaring Springs, Pennsylvania, as well as other places around the country. So thank you for being with us today. We hope that this consultant seminar that we're doing today will get us through our pandemic trials and tribulations that we're working with. So Dr. Marin's got some announcements to make, and we'll get ready for our next presenter. Thank you.
Thank you. Before we introduce our next speaker, I just want to remind you that you must complete the survey at the end of the conference. The survey is located on our website under the APER meeting information. It's also listed in the chat. The link is there for you to go directly to. At this time, we're going to go ahead with our pre-test questions, and I'll give you a few minutes to answer the questions before we start our next presenter, Dr. Tatiana Yiro. Okay, we're going to discuss those answers at the end, but everyone should have gotten the first question correct since we just heard about it from Dr. Ray. So our next presenter will be Dr. Tatiana Yiro. Dr. Yiro received her Doctor of Pharmacy degree from Nova Southeastern University. She went on to complete a psychiatric pharmacy practice residency through Nova Southeastern University in South Florida State Hospital in Pembroke Pines, Florida. She's currently the Associate Professor and Director of Admissions at the LECOM School of Pharmacy. At this time, please join me in welcoming Dr. Yiro. It's all yours. Go ahead and share your screen.
All right, perfect. Good morning, everyone. Thank you for having me. I'm glad to be able to participate in this way for all of you, and hope that everybody is staying safe during these crazy times. Today we're going to be discussing insomnia and treatment options for our patients. So let's get started. So we'll talk about some risk factors for insomnia, what common approaches to treatment are, and looking at adverse effects and particular drug interactions and issues with some of these treatments. All right, so first a little bit of background. Certainly insomnia is a very common issue. I certainly can say that I suffer from it very often, as I'm sure many of us can relate to that as well. And I will try to keep up with the chat box as well. All right, so sleep disorders do have an impact on our overall health, productivity, and quality of life. So getting proper sleep certainly is important for both our physical and mental well-being. Up to 50% of the population does report occasional short-term insomnia, and up to 10% of the population reports chronic insomnia. So that's when they're having an issue at least 3 times a week for a period of 3 months. So that can certainly be significant. The rate is higher in patients that have other conditions, particularly certain medical or psychiatric comorbidities. And it's kind of a catch-22 because insomnia is also considered a risk factor for many disorders. So each can worsen the other. As you can imagine, as patients' health conditions get more complex and treatment gets more complex, that medical expenses start to be on the rise. So that can certainly be very impactful for our patients. Polysomnography is considered to be the gold standard for sleep evaluation, and it measures a variety of things. It looks at the electroencephalogram, so it will look at the different brain waves that are occurring at a given time, and that clues us in as to what stage of sleep the patient is in during that time. We'll talk about that in a moment. Electromyogram, so monitoring muscle activity in the body, and the electrooculogram, which looks at the activity of the ocular muscles, which again helps us visualize which stage of sleep the patient is in. So again, the brain waves, the muscle tone, and the eye movements all combined are used to categorize sleep. And so we have both REM and non-REM. So REM stands for your rapid eye movement, and non-rapid eye movement sleep. So we will discuss those now specifically. Okay. All right, so overall, the stages of sleep, we refer to this as our sleep architecture. And there are 4 main stages of sleep. So each stage has a different function. From wakefulness, sleep typically progresses quickly through stage 1. So stage 1, 2, and 3 are all our non-REM categories, so non-rapid eye movement. So that stage 1 is our lightest stage of sleep. It's that transition period between wakefulness and sleep, and typically lasts around for those first 10 minutes or so of sleep. It's also called kind of a relaxed wakefulness. Then we progress into stage 2. So this is the stage that really provides rest for the muscles and the brain. We see muscle atonia, we see more low voltage brainwave activity. It's a slightly deeper sleep than stage 1. You see that temperature drops, heart rate begins to slow. And so this is as we are easing now into a deeper sleep. Stage 3 is what we consider our more deep sleep stage. And so in this stage, the muscles relax and we see blood pressure, breathing rate drop. This is when our deepest, most restorative sleep occurs. And this is where we see delta waves on EEG that is indicative of that deep sleep. This is where we see much deeper sleep, metabolic activity slows, everything just kind of slows down. So again, and then we have our REM sleep also. So this is when dreams occur. The brain actually becomes much more active during this time. The body becomes relaxed and immobilized, but this is where, you know, eyes move rapidly, hence the name of the stage. If you've ever watched anyone sleep, and I'm sure that's not creepy at all, but you know, you'll actually see movement of the eyes under the eyelids. And so that's why it has its name and how you can see when people are in that stage. So non-REM sleep, so our stages 1, 2, and 3, are essential for health maintenance. So that's why it's so important to, you know, kind of go through all these stages. REM sleep is essential for learning. So it's the time where we consolidate all the memories of the day, everything that has happened during the day. And it's also essential for mood regulation. So it's important to go through all of these and have the architecture of sleep be sound. We typically cycle through all 4 of these stages in about 90 minutes or so and repeat through them various times during the night. And as you progress through the night, you spend more time typically in the later stages of sleep. And we'll see as we talk about things that there are different medications and different issues that can impact different areas of sleep. All right, sleep states and age. Our sleep patterns do vary greatly over time. The most rapid changes occur in the very first years of life, and our older patients spend less time in deep restorative sleep, as you can see from the graphic there. So the elderly have a much more fragmented sleep. They have these intermittent arousals, shifts in their sleep stages, and a gradual reduction in their slow wave sleep. So sometimes some patients may not get any of that deep sleep at all. And so therefore they don't feel well rested during the day, even though they may have slept for several hours. They also tend to have an increase in early morning awakening. And they have an increased risk of other issues such as restless leg syndrome, sleep apnea, and so on. All right, so as far as categories of sleep disorders, we have primary and secondary. So we're going to focus on insomnia today, and that falls in the primary category as a dysomnia. But parasomnias so primary issues are looking at the mechanisms by which sleep is regulated. So parasomnias involve abnormal behavioral or physiologic events associated with sleep. So some examples of parasomnias would be nightmares, sleep terrors, sleepwalking, those types of things. Dysomnias look at abnormalities in the amount, the quality, or the timing of sleep. So insomnia falls in this category, but other examples would be narcolepsy, circadian rhythm sleep disorder, and some others. Secondary categories look at just other effects that impact sleep, so comorbid conditions and drug-induced situations. So like I said, we're going to focus in on insomnia. So insomnia is defined as, it's looking at the quantity and the quality of sleep, okay? So we're looking at patients that have difficulty falling asleep. So the time period to when a patient falls asleep is also referred to as sleep latency. So you may hear that terminology in this presentation. They have difficulty maintaining sleep, so they keep waking up in the middle of the night, early morning awakening, and then they're not able to go back to sleep. Or even though they've had sufficient opportunity to sleep, they do not feel well rested. So typically for insomnia, these patients, if they're having difficulty falling asleep, it takes them 30 minutes or longer in order to fall asleep. Young adults tend to more likely complain about having difficulty with falling asleep, whereas middle-aged and elderly adults are more likely to complain of that middle of the night awakening or early morning awakening. And women complain of insomnia twice as often as men. As far as classification, there are 3 general types of insomnia. You have your transient insomnia, which the best example of that would be jet lag, where your circadian rhythm, your internal clock, is offset because you've crossed several different time zones and you're readjusting to the time where you currently are. Short term, so we're looking at any insomnia suffering less than 3 months. And then once you have insomnia that persists for 3 months, occurring at least 3 times per week, at that point you're considered to have chronic insomnia. All right, so certainly there are a lot of causes and contributing factors to having insomnia. So what are some common causes? So who can tell me some situations, some issues that could be causing insomnia? All right, stress, of course, is a big one. Traumas, family issues, yes, loss of a loved one. Yes, absolutely. Worry, stress being high up there. How about some medical or psychiatric conditions specifically? Pain, yes, absolutely. Pain is one of those medical conditions that can significantly cause that. Panic disorder, mania, absolutely. Most of our anxiety disorders, depression, sleep apnea. Okay, very good. All of those things. What about some medications that can lead to insomnia? Because that tends to be a big problem as well. All right, some of our SSRIs, stimulants, of course, the ADHD meds that Dr. Ray discussed. Yes, alcohol can be an issue, and we'll talk about that, even though a lot of patients will self-medicate with those. Sudafed, so a lot of our over-the-counter products, caffeine. All right, very good. So yes, so really a lot of potential causes, and so we have to keep all of that in mind as we evaluate our patient, because a lot of this can be playing a role. All right, so let's start talking about treatment. So the most important step, right, is to thoroughly assess the patient, because we really need to figure out what's going on. We really need to get a detailed history of the patient complaints, because again, we talked about several different components of what insomnia is, right? It's looking at quantity and quality of sleep. So figuring out exactly what aspect they're having issues with will help better direct us as to our treatment choices. So are they having problems falling asleep? Are they having problems staying asleep? Are they waking up too early and not being able to fall back asleep? All of that. We need to thoroughly look at their medical and psychiatric history, because if we don't identify what the underlying cause is, then we may just be putting a Band-Aid on the situation. But if that underlying cause isn't addressed, whether it be a medication that's contributing to it, or perhaps it is, an uncontrolled underlying condition, then, just adding another medication on board is not necessarily the way we should be going. Medication use, we talked about that. Substance use. So a lot of different medications and substances, both legal and not, can certainly impact sleep and sleep quality. And so making sure, excuse me, making sure that we're identifying those is important. It may just be that we can change an administration time of a particular medication, and that might be all that's needed. So, but without knowing, we might just be piling on medications unnecessarily. All right, so let's talk about non-pharmacologic treatment first. All right, so for each and every patient, regardless of what else we do for them, we should be recommending sleep hygiene. So it should be a key component of your treatment strategy and patient education for insomnia. Let's kind of just go through this. So going to bed and getting up at the same time every day. So a lot of us probably have the tendency, you know, during the work week, we have to get up really early, although now if you're working from home, that may not necessarily be the case. But you get up early and then the weekend comes and you're tired and you decide you want to sleep in, or you decide you want to, you know, go out to dinner, hang out with some friends, that sort of thing, stay out late and just get out of your routine. And then what happens when Monday morning rolls around and you have to get back into that routine? It's difficult, isn't it? It's very hard to get up, you feel groggy all day, and it just really throws you off for a couple of days. So it is strongly recommended that you try to maintain the same rising time and going to bed time. And that'll help keep your sleep patterns in order. If you can't fall asleep or wake up and can't get back to sleep, get out of bed and do something relaxing. So you shouldn't lay there in bed trying to force yourself to sleep, because that's really not going to work. You want to get out of bed and do some sort of a relaxing activity, something with low lighting, something that's soothing to you. You know, don't go and blast crazy music or really go and watch a really action-packed movie, things like that. It needs to be things that are meant to help you relax. And once you start feeling groggy and drowsy again, then you can go back to bed and give it a try. Make sure your bedroom is quiet and comfortable, okay? That is key to helping us relax and be able to fall asleep. Now, this is the one I'm most guilty of, certainly, and I'm sure most of us are. Remove electronic devices such as TVs, computers, and smartphones from the bedroom. I'm sure a majority of us probably at least have a TV in the room, and I myself very much am on my phone or the iPad or other such device as I'm trying to go to sleep, which is terrible. But, you know, there have been studies that the blue light that is emitted from these devices can impact melatonin release and just in various ways contribute to us not being able to fall asleep as we should. So ideally not having those at all in the room, but certainly trying to limit their use between, you know, within those 30 to 60 minutes prior to wanting to go to sleep, and that can be very helpful. Use your bed only for sleep and sex. Again, just really kind of training your mind that that is what the room is for and not do other activities in there. Exercise, being physically active can very much help you fall asleep, have deeper sleep when you do sleep. We just have to be cautious of the types of activity if done too close to bedtime. So you shouldn't be doing any strenuous or vigorous activities close to bedtime. Keeping a sleep diary can be very helpful, especially for those with chronic insomnia, as they try to figure out different things that negatively impact their sleep, what things help them fall asleep, and it can help give a better picture of what works best. Limiting exposure to bright light in the evenings, again with the electronic devices as well, 30 to 60 minutes before bedtime. Establishing a relaxing bedtime routine, again, it's kind of prepping your mind and body that it is time for bed. Don't eat a large meal before bedtime. If anything, eat a light, healthy snack, but you know, between indigestion and just that uncomfortable feeling of fullness, all of that can negatively impact your ability to fall asleep as well. Avoiding caffeine in the late afternoon or evening. A lot of people are particularly sensitive. I think, you know, back when I was in pharmacy school, with as much caffeine as I consumed, it doesn't really seem to faze me very much anymore. I can have a cup of Cuban coffee in the evening and still go right to bed, but some people are super sensitive and they have to be very cautious with that. Avoid consuming alcohol and nicotine and THC before bedtime. Like I mentioned before, a lot of people will utilize alcohol to help them fall asleep. And while it does, in theory, put you to sleep because it does cause drowsiness, you'll see that it actually impacts your sleep architecture. So you actually don't go into that deep sleep, so that's stage 3. And so because of that, even though you sleep, you're not going to feel well rested because it is an issue. And reducing your fluid intake before bedtime, right? That's going to lessen the likelihood that you're going to have to get up in the middle of the night to use the restroom. And so remember diuretics too, right? Taking diuretics too close to bedtime would also cause you to get up. So that's just another medication that we would want to make sure that we are looking at. Here it just also lists the right amount of sleep, what's recommended for different ages. So for adults 26 to 64, it's recommended 7 to 9 hours, older adults 7 to 8 hours. So that would be nice to get that much sleep. Sadly, I do not, but that is what ideally is recommended. All right, so continuing on with non-pharmacologic therapy. So cognitive therapy is considered to be a standard of care, cognitive behavioral therapy, or CBT. It really helps address unrealistic expectations that patients may have and misperceptions that they have about sleep, and teach them different ways to deal with that. Relaxation therapy focuses on helping decrease arousal and in that way help initiate sleep. Stimulus control helps reassociate sleep stimuli with falling asleep. So again, removing that outside stimulus, the TV, the electronic devices as part of that. Light therapy helping readjust circadian rhythm, and mild sleep deprivation. Mild deprivation results in faster sleep onset and better sleep maintenance and quality. That's why we also don't recommend for these patients to nap during the day, because the more you nap during the day, the less likely you are to sleep in the night when you're supposed to. It's important to note that a significant number of your patients with insomnia that are treated both with sleep hygiene and these other forms of non-pharmacologic therapy do have a positive response. So we don't always need to initiate medications. Of course, there will be some patients that need to be on meds, some short-term, some more long-term. But if we do implement some of these non-pharmacologic strategies, we can make a significant impact. And even if they do require medication, we may be able to get by with less. Again, cognitive behavioral therapy is considered a standard of care and recommended first line along with the sleep hygiene education. Unfortunately, it's not necessarily accessible to patients all the time, whether because of availability or patient just really doesn't want to do that, unfortunately, or it could, more often than not, it's a cost issue and patients don't have the coverage, appropriate coverage for it. All right, so as far as pharmacologic treatment, we do have a lot of options. All right, so we'll start with our over-the-counter products. So overall, they're considered effective and generally safe. We're really mainly looking at mild insomnia here for our over-the-counter products. The two common components that you would see in these products are diphenhydramine and doxylamine. So both of these compete with histamine for the H1 receptor sites. Dosing is listed there. One of the issues is, and this is why it's particularly effective more so for mild insomnia versus chronic, is that the effect does wear off over time, that sedative effect. So, if you have a patient that's been, going to probably take it for just a few days or something like that, it's probably fine. However, once they've taken it for a week, a little over a week, that sort of thing, they're going to start to see less and less efficacy with it. And they're going to try increasing the dose, and that's not really going to help them either. Another issue is that these products do suppress REM sleep. So remember that REM is essential for learning and mood regulation. So REM sleep does play a specific role. So again, we want to try to maintain the integrity of that sleep architecture as best we can. And so while these can help temporarily, they're not, a long-term benefit. Again, you also want to be cautious with the elderly population because of side effects that occur with these agents as well. All right, so let's talk a little bit about some of the herbal products that are commonly utilized. So melatonin by far has probably the most evidence associated with it, the most studies done, and it is the one people think of the most when we're talking about sleep. So melatonin is an endogenous hormone that is produced by the pineal gland primarily at night. So during the day, we produce less melatonin, so we feel alert. And then at night, more is produced, and that's what helps you feel sleepy. And so this is what gets impacted and throws you off when you're experiencing jet lag, because now the timing is different, and you're having to kind of readjust that rhythm. So mixed results in studies, however, there is evidence of it being beneficial and helpful, and there are more and more studies out there lately. Recommended dosing is anywhere between 3 to 5 milligrams in the evening, 30 to 60 minutes before bedtime. They've also been doing, I think it's more common, people are using it more so in children these days as well. There are limited studies, particularly long-term studies in children, but evidence does suggest that in otherwise healthy children, the use of melatonin is considered to be safe. Let's see. Because melatonin does have some immunomodulating properties, it is contraindicated in patients with immune disorders, and also in those taking immunosuppressants. So, you know, like anything else, it's not totally benign. We have to be aware of some of those issues. So we just need to be cautious there. There are many different formulations available these days. There are extended release products. There are sublingual sprays and that sort of thing. Studies haven't really differentiated very much between them. So it becomes more patient preference and pricing at that point. L-tryptophan. So this has been thought to possibly decrease sleep latency. So again, that's that falling asleep and improving mood in patients with insomnia. It is a precursor to serotonin. So we've seen mixed results in studies, questionable clinical significance here. And there is the potential for a lot of side effects because of the fact that it is related to serotonin and we have those drug interaction potentials. Mainly what we see are GI adverse effects, and the recommended dosing is listed there, about 20 minutes before bedtime. So this one's out there, not really used as much. Valerian is another one that used to be utilized quite a bit. Biggest issues with valerian are a risk of hepatotoxicity, so I wouldn't regularly recommend this to patients. We have seen mixed results in insomnia studies, and it looks as though it works to increase GABA, though they don't fully understand specifically how it does that. Again, dosing listed there. Not as much significant benefit for sleep latency or sleep quality. So it can help patients kind of stay asleep, but it doesn't necessarily help sleep be best. All right, chamomile. So traditionally, chamomile preparations such as teas, essential oil, aromatherapies, and such have been used to treat insomnia, and because of its calming effects, induce sedation. So it's been used as a mild tranquilizer and a sleep inducer for centuries. There's a flavonoid as one of the components called apigenin, and this has been seen to bind to benzodiazepine receptors, and in that way activates GABA and exerts its effects. Again, often used in teas and aromatherapy. We are lacking in clinical trials. However, thus far, there doesn't really seem to be much negative effect of them. So it's a fairly safe route to try for patients, especially if they're trying to avoid medications and looking for more natural ways. Not really any side effects reported, and there don't seem to be drug interactions associated with it thus far. Lavender, also used historically, most commonly for relaxation and sleep. Again, it's thought to modulate GABAergic neurotransmission and exerts its effect in that way. Commonly used orally and even more so as aromatherapy. Again, limited studies available. Some case reports have shown some gynecomastia occurring. It does seem to have some estrogenic effects. So we need to keep that in mind and be cautious with it, particularly with oral use. However, otherwise it's fairly tolerable. So especially for short term, it may be effective, especially if anxiety is playing a role in the patient's insomnia because of its calming effects. All right, so moving on to our hypnotic agents, our prescription products. So we use a wide variety of agents here. So antidepressants, benzodiazepines, our non-benzo GABA A agonists, melatonin agonists, and more recently, the orexin receptor antagonists. All right, so we'll start with our antidepressants. So the ones specifically that are targeting insomnia are 5-HT2 receptor blocking antidepressants, namely trazodone and mirtazapine. 5-HT2 blockade with trazodone helps facilitate slow wave sleep and specifically reduces sleep latency and awakenings. It improves overall sleep efficiency when we compare it to the SSRIs. This selective blockade of 5-HT2 also partially reverses SSRI-induced insomnia and daytime activation symptoms. So both trazodone and mirtazapine, their best documented use is for restoring sleep in patients that are having insomnia that are treated with SSRIs. Also, and please note with the dosing here that the doses that are utilized for insomnia are lower ranges than what we use for depression. And so the reason for that is that at higher doses than these ranges, we start to see activation instead of sedation. So, you know, if the patient is not responding to these medications for their insomnia within these dosage ranges, then we do need to try something else because higher doses are not, an increase in dosage is not going to be effective. All right, tricyclic antidepressants, so amitriptyline and doxepin, specifically the extended release formulation is approved for insomnia. And these also help improve sleep continuity. Daytime sedation and side effects can be profound. So we have to be cautious with the patient population that we're working with, whether or not this would be appropriate. So for these reasons, it should be avoided as first-line therapy due to those side effects, especially in our elderly patients. If you have a patient that is suicidal or anything like that, because these can be lethal in overdose, so you want to be especially cautious there. Very low dose therapy is fairly well tolerated in other patients. Efficacy for long-term therapy has not been established, but especially if you have a patient that also has a chronic pain syndrome, then they might benefit in multiple ways from the tricyclics. And so in those particular patients, it may be worth considering. All right, with the benzodiazepines, so benzos are very safe. Fatal doses are rare unless our patient combines them with other CNS depressants, right? So if they're taking it with alcohol, with other medications, then they do than they are putting themselves at risk for respiratory depression. But alone in overdose, they are relatively safe. They do help reduce sleep latency. So again, help patients fall asleep and do increase total sleep time. So they increase that stage 2 sleep, but they do decrease REM and that deep sleep. So again, patients will sleep and they may sleep longer, but they won't necessarily feel well rested. So we should avoid them in certain populations, right? Obviously, patients that have a history of substance abuse, we should be avoiding these agents. In our elderly patients, we need to be very cautious. It can increase fall risk, hip fracture risk, and all of that. We want to avoid it in our pregnant patients as well. And as I mentioned before, patients should avoid alcohol use because it can lead to issues. So let me just take a peek here at the chat box. Any comment on safety tolerability profile comparison for patient over 65 taking Cylonor 3 to 6 milligrams versus Doxepin? So with the Cylonor, it does seem to be better tolerated. If we are going to choose to utilize those agents in the elderly population, it does seem to be safer to use the Cylonor versus just your regular release Doxepin at the higher dose. Yes. With the benzodiazepines, you know, a benzo is a benzo, so we really pick and choose between them based on their pharmacokinetic profile. There are some specific ones that are officially FDA approved, but they'll use most of them. Adverse effects associated with the benzo, so paradoxical reactions. So instead of seeing the sedation, we can see hyperactivity, hyperexcitability, anxiety, agitation. And those can occur more commonly with triazolam, and we see those more in children and in our elderly patients. Daytime cognitive impairment and sedation, particularly with those with a longer half-life. We can see a rebound insomnia with our shorter half-life agents. Rapid onset agents can come with anterograde amnesia. And if patients abruptly discontinue medications, we can see seizures from that. So again, part of our education to patients has to be, you can't suddenly stop it. If we want to take you off, we need to take you off and taper it down and that sort of thing. I mentioned before, risks with our elderly population, increased risk of hip fractures and falls, certainly also increased motor vehicle and pedestrian accident rates. So certainly not a benign choice of medication, very widely used, but not necessarily most appropriate. So like I said, there are 5 benzos that specifically have the FDA labeling for insomnia. As you can see from this list, 3 of those are some of our older agents and are quite problematic if you look at the half-lives. We certainly would not want to be choosing flurazepam or clozapam for our elderly patient because that could be very detrimental for them. So really of these, we focus in more on the temazepam and triazolam, but again, you'll see lorazepam used. You'll see a lot of the other benzos utilized commonly. All right, moving on to our non-benzo GABA-A agonists. So these are what we call our Z drugs. So we have zolpidem, zaleplon, and ezopiclone. So these agents act at the GABA-A receptor complex. They cause the chloride channels to open, which causes hyperpolarization. They are selective for the alpha-1 subunit. They overall show low to no anticonvulsant, anxiolytic, or smooth muscle relaxant activity at the usual doses. And in contrast to the benzodiazepines, with the use of these agents, we do preserve our sleep architecture. So it does not have a negative impact on our sleep stages. So it is better for our patients. And we also see a low incidence of tolerance or that rebound insomnia. Of the group, Zolpidem is by far the most popular. So this is our Ambien. So Ambien helps reduce sleep latency, so help patients fall asleep faster, helps keep them asleep. So it increases overall sleep time. We can see cognitive impairment the next day, which can be problematic. They've seen this particularly in female patients where the medication is not processed as fully. And so in recent years, we have decreased the dosing for women. There are, let's see, studies have been done more relatively short-term use, so 30 days. For those of you that work in the community setting, patients are certainly prescribed Ambien for a much longer amount of time than that. But ideally, it should be for more short-term use, and it still certainly has its risks as far as falls and that sort of thing. There are a variety of formulations available these days. You have your regular immediate release, there's a sustained release product, sublingual formulations, oral sprays. So other than the sublingual and oral spray, perhaps having a faster onset of action, they have not distinguished very much from each other as far as efficacy or, just being better versus the other formulations. Adverse effects, we can see amnesia, dizziness, so again, increased for fall risk, headache, GI complaints. There have been case reports of brief psychotic reactions. One of the big things that have happened with Zolpidem that have been reported are sleep-related activities or parasomnias. So things like sleep driving, cooking and eating while under the effect of this and not having any recollection, making phone calls during this time. So it's very important to educate our patients on the possibility of this and, educating their loved ones or, having them speak to people that they live with to kind of keep an eye out for signs of this, because obviously the patient themselves wouldn't necessarily be aware of that, unless it's that they were sleep driving and they woke up somewhere randomly, they would know. But otherwise, just with the cooking and that sort of thing, they may not know. So patients will complain of weight gain while they're on Zolpidem and come to find out it's that they're getting up in the middle of the night and raiding the refrigerator and they had no idea. So certainly if there's any evidence of any of these things occurring, the medication should be discontinued because of course it certainly puts the patient and others at risk. And puts the patient in dangerous situations potentially. So we would want to discontinue use should any of those occur. It's very important to have that conversation with the patient. Okay, Zaleplon is Sonata, and it has a very short duration of action, just a few hours. And it's most useful to initiate sleep. So, it's something that can be taken to help the patient fall asleep, but it will not keep them asleep. So if that's their issue, then this is not going to be the best choice for them. It can also be taken in the middle of the night. So if the patient has that issue of middle of the night awakening, can't get back to sleep, as long as they have at least 4 hours left where they can sleep, they can take one of these in the middle of the night. But also popular for long flights. Patients will use this to help them sleep through the flight. Because of its short duration of action, least likely to cause next day sedation, no psychomotor or memory impairment, again, for the same reason. Let's see, some drug interactions of note, cimetidine can increase levels significantly and rifampin can significantly decrease. Ezopiclone is Lunesta. It's the commercial with the little butterfly flying into the bedroom. So this one, in contrast to the other two, has been studied more long-term, up to 6 months. This one is useful to both initiate and maintain sleep for up to 8 hours. So it does increase total sleep time and also increases sleep quality. This one loses a little bit of the selectivity for those alpha subunits. So you do tend to see some mild anxiolytic, muscle relaxant, and anticonvulsant effects in comparison with the other two agents we just talked about, particularly at the higher doses. The most common side effects are listed there. Unpleasant taste has been reported in up to 34% of patients and is one of the most common reasons for discontinuation. All right, so we talked about melatonin's role in sleep regulation, and so they've developed these melatonin receptor agonists. So MT1 and MT2 melatonin receptors are thought to regulate circadian rhythm and sleep onset. So these agents have a high affinity for both of those, and they're selective for MT1 and MT2 over the MT3 receptor. So they have no affinity for GABA receptors, so it's strictly impacting melatonin receptors. We have two agents in this group. We have Ramelteon and Tasimelteon, which is specifically for non-24-hour sleep-wake disorder. I'll talk about in a second. Some advantages with these agents is that they're not controlled substances. So in a patient with a history of substance abuse, this could be a reasonable choice. All right, dosing is listed there for you, and adverse effects. We should avoid fatty foods. So Tasimelteon, as I mentioned, is for non-24-hour sleep-wake disorder. So this is for patients that have difficulty with obtaining restful sleep because their circadian rhythm is not synchronized with the 24-hour day-night cycle. And so this is most often present in people who are totally visually blind because they don't have those light and dark cues that cause the natural secretion of melatonin. So this is the first drug approved for this condition. It can take weeks to see effect, unfortunately, and it's not recommended in patients with severe hepatic impairment. It can lead to abnormal dreams and headache. All right, so our newest agents are the orexin receptor antagonist. So the orexin neuropeptide signaling system promotes wakefulness. So by antagonizing this, we can decrease wakefulness and thereby initiate sleep. So suvorexant was the first agent. Belsomra came out a few years back. We have to be cautious with patients that are on strong 3A4 inhibitors because it is heavily metabolized by 3A4. Patient needs to have at least 7 hours left to sleep. It can cause symptoms similar to narcolepsy, so we can see sleep paralysis, which is where patients are trying to wake up and move and they cannot. Hypnagogic and hypnopompic hallucinations, which are those hallucinations that occur in that transition phase where you're falling asleep or waking up, kind of that hazy, am I still asleep, am I awake? And so patients can experience those hallucinations and cataplexy-like symptoms. They can have abnormal dreams. They can worsen depression or lead to suicidal ideation. So we need to monitor our patients and be cautious of which kind of patient we select for this. And this class can also cause sleep driving and other parasomnias similar to what we saw with the Z drugs, particularly the Zolpidem. Most recently, lemborexant or Dayvigo was approved. So it was just approved back in December. Controlled medication, it's not physically on the market yet, but should be soon. And this one does have more long-term studies associated with it up to 6 months. And actually even longer, so they studied it for up to 12 months as well. And so they're hoping that because it has, longer evidence behind it, that it'll be a good option for patients. All right, so a question here. So we have a 45-year-old patient that comes to you for help with sleep difficulties. She reports laying in bed for hours before she can fall asleep. In addition to that, after falling asleep, she keeps waking up every hour or so. This happens often, particularly in the last couple of weeks as she's been preparing for an inspection. She states that she's tried taking diphenhydramine 25 milligrams at bedtime, but it has not been working as well. In the past couple of days, she manages at daycare, worries about feeling groggy the next day. So in addition to sleep hygiene, what do you think would be the most appropriate? All right, so I'm seeing you all between two choices, so B and D. All right, so let's talk about that for a second. So the diphenhydramine, 50 milligrams, so we've established that once the diphenhydramine stops having efficacy, adjusting the dose is not effective. So clearly that's not the right answer. And the doxepin can lead to significant daytime sedation the next day potentially. So that leaves us with the Zaleplon and the Zolpidem. So you could argue both, okay? So with the Zaleplon, she could take it, it can help her fall asleep, and then if she does wake up a few hours later, she can retake it, and she would have the least issue with sedation the next day, right, because of its short activity. So that is very much an option. You would probably need to dose it again in the middle of the night, potentially. But Zolpidem 5 milligrams would also be appropriate if she takes it early enough. The dosing is appropriate for a female patient. Normally we go up to 10 milligrams, but females, because we have more difficulty in metabolizing it, the 5 milligrams would be an appropriate choice to decrease that positive next day sedation. So you could kind of argue both of those, and both could potentially be an appropriate answer. So very good. All right, so as far as the insomnia treatment guidelines themselves, they reviewed the common dosages and looked at those medications that were both FDA approved and the ones that are most commonly used off-label. And so overall, most of what's commonly used was recommended, except for those listed there. And again, mainly because the evidence is not as strong, right? So trazodone, you know, yes, we use it, but other options are more appropriate. Diphenhydramine, because of the side effects, is not always ideal either. Our herbals, again, because we just don't have as much evidence, and also the fact that we don't have regulations that really guarantee that the patient is getting what they think they're getting in a particular batch. So that also kind of confounds things. As I mentioned before, non-pharmacological treatment is considered the standard of care. CBT is particularly important and is considered first-line treatment for all, in addition to sleep hygiene. Again, not always accessible to patients or acceptable for patients. Pharmacotherapy should then be initiated in patients who either failed with non-pharmacologic treatment, if they don't have access to the non-pharmacological treatment, or in the ideal setting, used short-term in combination with that non-pharmacologic treatment, because studies have shown that the combination is better than either modality alone. So to summarize the guidelines, again, CBT first line. If you're going to initiate pharmacologic treatment, the ones listed here are best if the patient is specifically having the issue with sleep onset. So you see our Z drugs, our benzos, Ramelteon, because again, all of these help shorten the time it takes to fall asleep. Sleep maintenance, those are listed there. And then again, the products that that the consensus did not overall recommend. All right, here's another question for you. Actually, 1 second, in the chat, I'm seeing what exactly is light therapy, and do nursing homes have access to this? So no, to my knowledge, it's not as readily available. Light therapy basically is exposing patients to light during certain times of the day, and it's basically trying to trigger that day and night cycle to help regulate more of the melatonin release. So probably not as available. So this question here, which of the following are true regarding sleep disorders? So insomnia involves issues with falling asleep, staying asleep, and feeling rested after sleeping. Pharmacologic agents are considered first line. Trazodone 300 at bedtime is appropriate. And so it looks like almost unanimously, everyone selected A, and that's correct. So insomnia is looking at quantity and quality of sleep, issues there. So falling asleep, staying asleep, and feeling rested after sleeping. Remember, pharmacologic agents are not considered first line. We always want to use those non-pharmacologic agents first. Trazodone is utilized for insomnia. However, 300 milligram dose is too high. Remember that I said that once we get to doses above that, about 150 mark, you can maybe push it to 200, but really beyond that, it has more of an activating quality and therefore is no longer appropriate for insomnia. That becomes more of your depression range dosing. Let's see. So to summarize, sleep disturbances do affect a significant amount of the population, and insomnia is certainly the most common within that. They can affect a person's ability to function right. We talked about the different roles that the different sleep stages play as far as mood regulation, memory consolidation, just physical rest for the body and all of that. So especially long-term issues with sleep can have significant consequences. Pharmacists can play an integral role in treatment and certainly certainly can be helpful from the patient education standpoint. Several options, so we really have to kind of hone in on what is specifically going on with the patient and thereby help out. So one of the questions, why is trazodone so highly used in ALS if it's not first line? Cost, availability, it's relatively well tolerated. There's just not as much evidence specifically looking at insomnia, but it is widely used in the hospital settings and things, and it's been found, relatively safe and effective. And so, and cost certainly plays a big issue there, plays a big role there, rather. All right, so I always talk a little bit too fast, even though I try to pace myself, but what questions can I answer for you?
There, we have some questions that are in the Q&A section there.
Okay.
I don't know if you can see it on your screen. If you want to click into that and take a peek at those.
Sure thing. All right, let's see. All right, so which medications help to increase stage 3 and 4 sleep and possibly REM sleep? Well, again, the medications, the Z drugs do help maintain the integrity of the sleep architecture. So while they don't necessarily increase it, they maintain it at where it should be. And so it helps you go through all the stages in a more normal physiologic way. So if the patient is having issues with that, that is a good way to target that. Let's see. Just reading through here. Trazodone is also a non-controlled substance, which is why it is also used so much. Absolutely.
And we also have some questions from raised hands. So I have Sharon that would like to pose an oral question to you. So I'm
Okay.
selecting the button that would allow her an opportunity to pose her question where everybody can hear. So Sharon, you're on. I can't seem to get her unmuted. Okay, apparently I'm having trouble with her. So I'm going to our second raised hand, and that's
Okay.
Robert Ritter.
Okay.
I'm trying to unmute him. Ah, looks like we got Robert in. So Robert, oh, try one more time, Robert. There we go. Yeah, raise your question, Robert. Okay, apparently Robert's microphone's not working. We're going to give Claudia an opportunity to present to the group. So Claudia, I'm going to unmute your microphone. Okay, so I can't get Claudia's microphone to work. We have Joyce, who has a question as well. So I'm going to unmute Joyce's microphone. Somebody's microphone's got to work.
Well, while you try to do that, I'll go ahead and answer some of the other questions, and I'll hush if you're able to get somebody. So do I have an opinion on weighted blankets for increased sleep quality? The weighted blankets have become much more popular lately, and they do seem to have that relaxing and anxiety calming effect. So in that regard, it does seem to help patients get into a deeper sleep. And so, yes, another non-pharmacological recommendation that we can make to patients that could potentially help them. Melatonin long-term use and concerns with natural release of melatonin if that's impacted. Again, that's part of the concern, and there's just really not as much long-term evidence that's consistent available out there. It's, some studies say it's safe, some say it does seem to impact that. So it really just depends. And so that's why there's still some concern, even though it seems to be effective, there is some concern regarding use. Concern with serotonin syndrome when using mirtazapine to treat insomnia in patients on SSRIs. Yes, of course. You always run an increased risk as you start increasing medications that do have an impact on serotonin levels. So you certainly need to proceed with caution. Again, with the mirtazapine, when you're using it in those situations, you are using lower strengths, lower milligrams for that. So, hopefully that's less issue. And you just have to monitor your patient, educate them on symptoms of serotonin syndrome. But the rate is still relatively low, unless you have multiple medications, right? But if you're just on the SSRI and you're adding the low dose mirtazapine, not as high of a risk. Let's see. Sift through these. Sorry, there's a lot of questions coming in, so let me see. I guess I can end the slideshow too. Sorry guys, bear with me a second. Okay. Let's see. Can you give Benadryl and melatonin? So you could, they don't interact with each other per se. More sedation potential, right? I would certainly do the Benadryl more short term, again, because of the issues associated with it, but not necessarily a problem. Again, just kind of depends on who your patient is. If it's an elderly patient, I would hesitate to give the Benadryl, to recommend the Benadryl at all because of the side effects, and I would try more the melatonin route. Let's see. Melatonin dose for a child, again, kind of more in that lower range, that 3 to 5 milligrams seems to be where most of the studies are. Have you seen any difference in prevalence rates of insomnia by geographic issue, by geographic region? Yes, actually. So areas where you have more times of day or more times of night, particularly up north, Alaska, and that sort of thing, again, because you don't have those such clear day and night triggers. And yes, you actually do see a larger rate of insomnia. And so in those areas in particular, they use things like that light therapy and that sort of thing, which they also use for like seasonal affective disorder and things like that. Let's see. Some new questions popping in here. Youngest to give melatonin in a child. They have looked at it under the age of 5. I want to say probably the youngest I saw in studies was like at the age of 3. My personal thoughts on giving melatonin to kids under 5. Several patients wanting to give melatonin to 1 to 2-year-olds. You know, it's a tough one. It's a tough one. You know, and as a mom, you know, I always kind of go through that myself, you know, even seeing the evidence and kind of still being hesitant in spite of the fact that my daughter is 6 now and that there are studies that back it. I would still be hesitant and so young because they're not able to express what's going on, and maybe there's other issues that are leading to them having trouble sleeping. So I would still be hesitant, and I don't feel that the evidence is strong enough to be able to solidly recommend for quite that young. Let's see. All right. I will provide my email address in the chat if you guys have any questions that you want to send me later on. By all means, let me look over on this side. There's too many places for questions. Give me a second here. Right. All right. Question with trazodone and hydroxychloroquine. You know, certainly potential increased risk with arrhythmias and things. So certainly would need to be closely monitoring the patient. You know, I would probably want to hold the trazodone during that time if we feel that the hydroxychloroquine is being most appropriate now for COVID-19, which I guess is still up for debate. Can Michael do the moonwalk on video now? That would be wonderful. I second that.
Yeah, I'd like to see that too myself.
That would be fantastic. Favorite question there for sure. All right, I think I have hit most of the questions. I apologize if I missed any, but I did provide my email. So if I missed your question, or if you have a question after the fact, by all means, please shoot me an email and I will be happy to address your question. Thank you so much for your attention. I'm happy that we were still able to do this. And please, everybody, stay safe. Thank you so much to those that are still out there exposing yourselves to help people. You are very appreciated. Thank you.
Thank you, Dr. Uro, for that awesome presentation. We're going to take, before we take our break, and we're going to hear from Dr. Sahela Madavian on schizophrenia. We're going to have a few comments from FPA's president, David Mackery.
Thank you, Tian. Hello, everyone. My name is David Chachi McCary, the current president of FPA. I want to personally thank you for your participation in this weekend's conference, especially during these difficult and challenging times. It certainly has changed our new